Welcome to another episode of the Melbourne Athletic Development Podcast. We are very lucky today to be joined by David Delahar. David, could you do us the pleasure of giving us a little bit of background of who you are and what you do?
Well, currently I'm an orthopedic spine surgeon practicing out of the Epworth Hospital. I started life, my first degree that I finished was actually in chiropractic. I was then the first chiropractor in Australia to go back to uni and finish medicine, and from there I did orthopedic surgery and subspecialised into spine surgery after training in England. And I've been working as a spine surgeon for 22 years now.
It's pretty impressive that you were the first person to go from chiropractic training into surgery.
I'd actually done a few years of medicine straight from high school. Yep. And was a bit disillusioned with it, so I dropped out and then thought I'll do something really radical. So I went and did chiropractic, yep, much to my father's horror, and then thought I probably wouldn't practice chiropractic for the rest of my life, so I went back and finished the medical training.
What made you sort of get disillusioned with the medical world?
It was basically the course subjects in the first 3 years I thought were inappropriate for clinical practice, and subsequently a lot of that has been changed now. Everything that I was objecting to has been...
what kind of stuff was it?
All very pure basic science stuff that really didn't translate into clinical practice and health, and it's become a much more clinical course now. So a lot of that laborious subjects like biochemistry and stuff like that, and organic chemistry in first year I hated. Really, that was just far too much of that sort of stuff, and most of that's been chopped way back now. Most of our lecturers in those days were scientists, of course, and so they were teaching us what they did for a living, and that didn't really translate into, I felt, medical practice. So I was a bit of a rebel, I suppose, and paid the price for it, but by the time I went back, things had changed quite a lot.
Looking back now, do you see that those basic sciences could have been useful, or do you still think that clinically it's more important to kind of get that foundation?
The basic sciences are useful, but the depth that we had to learn it in, and the practical experimentation and things like that we had to do was just over the top, I felt. Even, I'm a surgeon, so I'm supposed to know my anatomy. Even the depth of the anatomy that we had to go into was, I thought, far too detailed, and that I think has been watered down a fair bit, and more emphasis has been put on learning anatomy for clinical application rather than pure academic application, if you know what I mean.
So you were doing like lab experiments and things like that when you're doing your basic sciences.
Yes, and hundreds and hundreds of hours of dissecting cadavers. It was just, I thought it was just way over the top, and 90% of medical graduates don't need that level of anatomy to do their job. So, but it's changed a lot now, and it's a lot more clinically oriented, I feel.
Did you appreciate that depth of anatomy when you went back to do your surgeon's training?
Well, we had to relearn all the anatomy anyway, so we had to do it all again. And even though I was training in orthopedics, we still had to do everything all over again for what's called the first part surgical exam. So it was torture all over again, learning all about the viscera, if you like, something that we would never see as an orthopedic surgeon.
We spoke last week actually with an orthopedic surgeon who had training. Obviously, he's now a hip specialist, but he had training in vascular surgery, in plastics.
Oh yeah.
And he spoke about the concept that having some more of that general broad knowledge is very useful, particularly when things don't go to plan in the surgical realm. Have you sort of in any way drawn on some of that, the things that you didn't like, the viscera learning and all those kind of things because my suspicion is that spinal surgery sometimes is a little bit more tricky than other areas of orthopedics.
Spinal surgery is quite a specialised area of orthopedics, but as part of your general surgical training, you do, as a junior house resident, you do rotate through the other specialties for 3 or 4 months at a time. So you do get a taste of what the plastic surgeons do, what the general surgeons do, although you never actually have to perform those surgeries yourself. But it gives you an appreciation of when perhaps you should refer the patient on because something else is going on rather than your little area. So that's important, but so I agree with the orthopedic surgeon that you said with his comments as well. Yeah.
The to me, with spinal surgery, it seems like there seems to be two streams. People who either go and see neurosurgeons or orthopedic surgeons. From your perspective, obviously you've come from the orthopedic side. What is, in your mind, the difference between the two? Is there a difference? And if someone is, say, having something that's going to need surgical input from a spinal injury, you know, what kind of things should they be looking at, and what kind of surgeon they should be looking for?
There should be no difference at all between the neurosurgeon and the orthopedic surgeon as far as diagnosis and treatment. When we finish our basic specialty training, I mean, as an orthopedic surgeon, I was trained to do hips and knees and fractures of the long bones, etc. The neurosurgeons are trained to do intracranial work, and we both get a little bit of introduction to spine surgery, but then I think it's important, once you finish your basic surgical training, to do what's called a fellowship, which is extra training in your subspecialty, which is what I did at Queen's Medical Centre in Nottingham, England, where I spent 14 months just operating on spines 7 days a week. And if you're a neurosurgeon, you should really do that advanced training as well. And by the time we've done that, really there should be no difference between an orthopedic or neurosurgical spine surgeon.
And what drew you to the spine? Like, what was it about spinal surgery? Because I would think, even just for me, who is not going obviously anywhere near this path, there would be some fear around going towards the spine if you were an orthopedic surgeon.
It wasn't a very popular subspecialty when I went through over 20 years ago. There's, I think, a lot more risk associated with spinal surgery, and therefore a lot more pressure. I think because of my previous life as a chiropractor, I had an interest in spinal disorders and treatment of the spine, so I guess I naturally drifted down that pathway.
Do you think working as a chiropractor gave you, those experiences were very useful when you went into being a spinal surgeon?
Absolutely. The chiro course does cover a lot of clinical training as well into all sorts of disorders. And when I went back as a fourth year medical student, I felt quite ahead of the rest of the pack, because I had already been exposed to courses on lung disease and heart disease through my chiropractic training, let alone x-ray diagnosis and orthopedics and rheumatology. Of course, I was way ahead. So I was at quite an advantage going back. Did
you also give you some appreciation for thinking about appropriateness of conservative versus surgical management, do you think too?
Look, I think so, because I had a better understanding of what can be done conservatively, either with chiro, osteo or physio, or myotherapy or exercise therapy, compared to my colleagues. I think that's one of the strengths of my reputation, is that I seem to have a reputation for treating more things conservatively than surgically, compared to a lot of other spine surgeons.
Yeah, one of the things that, and we obviously haven't met, I know that you've known Jack for a while, but one of the things that we always think about when we either refer to a surgeon, and your name always comes up in this, is we know that you will do surgery if it's appropriate. Right? And so, like, I remember I've had this conversation with Jack a few times. It's like he's reached out to you for questions or whatever, and he knows that the response he will get from you is one where you will not say that surgery is needed unless it truly is, or it's going to have benefit clinically.
Well, that's how I like to work. Yeah.
Is that something that you had to develop in your own sort of professional decision-making process, or is it something that you think was influenced by that previous training?
I think it's probably influenced by my previous training, really. I know what you can do with your hands and with the exercises, and so I always encourage the patient to take a little bit of control of their own condition, rather than patients coming with expectations that I'm just going to lay on the operating table and Dave's going to fix everything for me, And some patients do have unrealistic expectations about what can be achieved through surgery.
We've had a few surgeons on recently, and that seems to be the question that always comes back to them, is how do you deal with those expectations? Because there is this overriding sentiment, I think, even in the general populace, that once you reach the surgeon, that the buck stops with them and they're going to be able to fix you. But as you said, that's sometimes an unrealistic expectation.
Well, surgery doesn't fix everything, and there was a sort of an axiom that we were taught in fourth year, that surgery is for failed medical treatment. In other words, you do the two disciplines in medicine are medicine and surgery. Medicine is generally non-interventional, and surgery is interventional, and so you reserve surgery for when conservative measures have failed.
Do you think people forget that sometimes?
I do, and sometimes patients get fed up with me or angry with me because I won't operate on them, and it's always disappointing to find out that they've gone somewhere else and had an operation which may not have actually gone well.
It's an interesting one that Jack and I, even just this past week, we had a patient that we were discussing who we actually communicated with him, but he said he went off and did something, and the diagnosis that the person gave them was a bit fluffy around the edges, and we sort of thought, what was this patient searching for? Were they searching for someone to say, this is the problem, I'm going to fix it, because that makes them feel better? I would say that probably happens more to you at times if you're pretty clear. And I think it's an issue sometimes that you have as you get more experienced. You probably get better at discerning when there isn't going to be a result that you can give them. And patients sometimes don't like that at all.
No. Well, particularly based on the time frame in which you think they're going to see improvement, because I guess the assumption often is surgery is going to be instantaneous, which it actually may be in terms of relieving certain symptoms, but there's obviously an associated recovery process, and associated with that is rehabilitation, as opposed to conservative management, where if you're applying lifestyle or exercise interventions, the process of adaptation takes a lot longer. And that can be a very difficult sell for some people who, understandably, they've actually been in a lot of pain, just come for a long period of time, wants a more instantaneous result.
Yeah, I think when you talk about surgery for low back pain, that's the thing that's given spinal surgery the bad name that the general public have about it, because it's so unreliable, and so difficult to determine for low back pain which operation may or may not help, because it's a very vague area as to where the pain generator is coming from.
And why do you think that's the case?
I think the structure of the lumbar spine is so complex and so richly innervated with nerves that there are multiple tissues which could be pain generators. There are the facet joints, the articular surfaces, the joint capsules, the ligaments, the annulus fibres, and you often get patients with multi-level degenerative change. Every disc and every joint in the lumbar spine is bad, degenerate, arthritic. What do you do? Where do you operate there? Where is the pain generator? So it can be very difficult to isolate the diagnosis to try and do an operation which may help them. Low back pain surgery is not a very big part of my practice. In other words, fusion surgeries, those sorts of things. You have to sort of be able to isolate one area, which is quite clearly the pain generator, before talking about fusions and whatever. I mean, I use a lot of injection procedures, either under radiology or with myself, for like facet joint injections, nerve root blocks, those sorts of things, to A, try and help people, and B, try and isolate where the problem's coming from.
So it's very much like a diagnostic tool as much as a therapeutic?
Yes, it can be both diagnostic and therapeutic, for sure. The good parts of spinal surgery, or the more reliable ones, are of course where you've got nerve root compression. People with raging sciatica, intolerable leg pain, and a disc proven on MRI causing compression. Well, that going in there and just removing the pressure on the nerve has a 97% chance of giving them instantaneous relief. And they're the most happy people I've had to operate on, those sorts of people. But the patients with multi-level degenerative change and back pain, I usually say, well, sorry, you've got to go back to the physio, chiro, osteo and learn to adapt your life to deal with this. There is no magic wand for your condition.
Talking about pain-generating tissue, one tissue that you didn't mention that I think is of interest is the muscular and fascial system.
Yeah, sure.
And the issue that we have with that is, unless there is a clear loss of structural integrity, if they have a strain, which doesn't seem to be very common, say in the muscular tissue around the lumbar. But are you aware of any research, or do you look for potential changes within the soft tissue structures that may generate pain? And if so, how do you go about trying to quantify or determine that?
The fascial structures, that's quite a grey area, and the musculoskeletal medicine practitioners lean more towards injections into fascia, etc., or doing certain procedures where they incise fascia percutaneously. A lot of the muscular pain, I feel, is like a guarding spasm for an underlying problem.
Yes.
So you have an underlying problem, the body automatically goes into protection mode, calls upon the erector spinae group and other muscles to lock on to protect and stop movement, and you get a lot of pain from the muscle spasm associated with it. So I think you're right, that's another potential pain generator, which is sort of indirectly related to the underlying problem.
Yeah, it's an area that I'm particularly interested in, and I think one of the issues you have with regards to myofascial pain is the inability to effectively quantify it through some type of radiological investigation in particular. It's actually, I know there's very interesting research coming out of from Carla and Antonio Stecco, who I don't know if you've heard of them before, but of looking at changes within the soft tissue constituents. So specifically looking at the extracellular matrix and particularly within the loose connective tissue, and seeing changes in hyaluron and how much it binds water. So I know there's actually some interesting research of looking at quantifying unbound water as an indication for changes in the extracellular tissue matrix that changes the gliding between different layers.
Yes.
That seem to be nociceptive, but it seems to be one of the big issues is the ability to effectively or objectively quantify that, because at the moment it seems to be very much a clinical diagnosis as opposed to a clear diagnosis.
In my chiropractic training, we talked about trigger point therapy.
Yes.
Trigger points were the words, and they were felt to be a concentration of hyaluronic acid.
Yes.
And they were diagnosed by palpation, of course, because that's what chiros have. We have 10 fingers to feel for these hard lumps, and they're painful. And then the manual therapist would press into these trigger points to break them down and disperse them as a form of relieving muscle spasm and pain. The musculoskeletal medicine practitioners would inject them with local anaesthetic and sometimes cortisone. So I think that's probably what you're getting at. But imaging for them, you can't see them. It has to be a clinical diagnosis by feel.
Well, yeah, I mean, I'm interested to see how that particular field evolves, because I know they're trying to look at how you can quantify that by looking at whether how much water is bound versus unbound, and actually seeing how particular types of manual therapy can change the extracellular matrix, and obviously that's the association of that with pain. But is that something, though, for you? It sounds like you, being both a manual therapist and you previously, have more of an appreciation for manual therapy. Do you think that has a role in treating pain and treating lower back pain?
Definitely. I mean, apart from operating, once a month I do a list of injections under sedation, and these can be into facet joints or into trigger points that I can find. You can get them done under CT guidance, but they would have trouble finding the trigger points, but sometimes if it's only one facet joint, I'll get them to go to a CT scan and have it done, but they're awake and it's a bit painful, whereas often I'll do 4 facet joints or 6 facet joints at a time under sedation to give them a little bit of propofol, Michael Jackson drug, and relax them, and then pop in the injections. And I often then combine it with a little bit of a manual tractional therapy or manipulation, because of my previous training, to gap the joints or open the joints up.
Is that common for people to do that kind of injection therapy?
No, I think I'm probably one of the only ones that may be doing it. I mean,
and what kind of effect do you get? Do you see significant changes for people where that is their clinical driver of their pain?
If it is, like in the last 23 years, I've got people that have been coming to me once every 6 months, every 3 months for these injections, because it's the only thing that keeps them going.
And they're people that you think surgery would not be appropriate?
Not be appropriate.
Yeah, that's quite interesting. And do you feel like, obviously, it's quite impressive that you've seen this interaction between your previous training and now, your more current surgical practice, where you've been able to combine them. We talk a lot about this concept of being able to utilize knowledge across different areas of understanding and study. Do you think that that's where innovation comes from? Like, it sounds like you've created something a little bit innovative in terms of your practice.
I think that the procedures have always been around. In fact, I learned facet joint injections in my clinical training in Nottingham in England,
yes, yeah.
And brought it back. But no one else was doing it here at that time, and no one seemed to be interested in doing it. So that's where I started. And
what about the trigger point ones? Because that to me sounds a little bit different to what most spinal surgeons would do.
Oh yes, I think the musculoskeletal medicine practitioners probably do more of the trigger point type of work than anyone else. But I notice in the physio profession, there's been almost an explosion of dry needling, which I guess may be similar to the trigger point injections. I'm not sure. Yeah. But that seems to be, I don't know what you feel about that, but a lot of the patients come to me and they say, oh, the physio did acupuncture. And I said, no, I don't think he did. I think he did dry needling. Yeah. So that seems to be really taking off. And
I think it's sort of driven, whether it creates anywhere near the same effect, I think it's the underlying theory is similar.
Similar, yeah. Yeah. I think that if I had a criticism, my background, that I'm patron of an organisation that is, we put together postgraduate educational seminars for the chiros, and the osteos and the physios can come as well. But I've been talking for 25, 30 years about trying to bring all three professions together. There shouldn't be a chiropractic profession, there shouldn't be a physiotherapy profession, there shouldn't be a separate osteopathic profession. I put forward 25 years ago, I said we should all train in the same place, exchange our ideas, and everyone should be called an orthopractor.
Yeah.
We should get rid of the names, we should get rid of the philosophies and pool it all together, because everyone's got something to offer for that conservative pathway.
I think that's a really good idea. It's interesting that I'm not surprised that it hasn't taken off, but it's a good idea.
I think the issue you see too, and physiotherapy is as guilty of this as others, is people become a little bit too ideological about their particular profession and quite quick to dismiss other professions' value. And it's interesting, I did a course in Sydney a few weeks ago, and it was a course that's the actual particular method is not very common in Australia. It's called fascial manipulation. It's from this Italian group. And interestingly, there was a chiropractor and an osteopath on there. And I actually really valued talking to them because, well, one, they were clearly both very switched on people, and they had experiences or knowledge that I didn't have, and hence sparked my curiosity. Because I think that's an issue where you assume that the knowledge that you've been given is the absolute and only knowledge.
Correct.
And I think particularly too in manual therapy, which is a relatively grey area in the sense that there isn't a lot of research into it. And I think people can be very dismissive of looking at the applied research, but the reality is in the real world and clinically, you clearly get a lot of therapeutic benefit, for whether it's related to, say, manipulation, which is obviously what a lot of chiropractors do, or other manual therapy techniques. But I think it'd be a lot better if we actually talk to each other a little bit more openly.
I think if I look at the criticism of the three professions, chiro, osteo, physio, is that chiros and osteos predominantly do a lot of hands-on therapy, but ignore the exercise rehab side of things to a degree.
Well, I think they're starting to do a lot more training in that area from what I'm hearing from people who are in those courses. They're trying to combine some of that knowledge now, which is good.
Yeah, and the criticism of the physios, which it's changed a little bit now that you've got the post-grad manip therapy stuff that you can do, is that
they're being phased out though too.
Really?
Yes.
Yeah, it's going the other way. Yeah, we have this criticism that where the profession is heavily losing its manual therapy understanding, because they've adopted this idea that you need to only use applied RCT-based research as the foundation of your clinical practice, which in manual therapy, as you would know, is very difficult to actually conduct.
Yeah, I think the physios rely too much on the electrotherapeutics, ultrasound, dry needling and exercises, and not enough hands-on therapy. I don't know why the postgrad manual therapy would be phasing out, because I was really applauding it when it came out. I was a little disappointed because, for years the physios were I'm talking about in the 1960s now, were criticising the chiros and trying to get the chiros deregistered because they just struggled and got a registration board, which I sat on for some time, and became sort of more accepted, and health insurers were covering the chiropractic treatments, and the physios were going hammer and tong trying to stop this. And then they turned around and set up the postgrad manipulative therapy course, and I looked at their textbook, and what they had done was they'd got our basic textbook from a chiro course that I did at Phillip Institute. They'd whited out the word chiropractic and written in manip therapy, and it was the same stuff.
Wow. The
same pictures, the same, I was furious about that. I was glad that it was being taught to the physios, but talk about, two-faced.
Well, look, it's become a real issue too, where particularly there's a big divide between older physios and younger physios, because it was very much more manual therapy based, say 20, 30 years ago or 30, 40 years ago, where now it's much more exercise based. But it's very problematic because manual therapy is very much an art form that you only get better with practice. Constant hands-on experience. And your ability to feel, which it's probably one of the issues we have with trying to quantify everything all the time, because we forget about the qualitative nature of being able to appraise and determine what are contributing factors to someone's presentation, particularly with what you get with feelings and putting your hands on someone. On someone.
The chiro course is quite long, I think. It's about a 5-year course, or it was when I went through, although I did it in half the time because I already had half my medical degree done, so I was able to compress it up. But it does take a long time to develop those hand skills, and I think that's why the course is as long as it is. Plus there's a lot of diagnostic subjects that they teach along the way, and a lot of radiological interpretation subjects and those sorts of things.
One of the other things too, and correct me if I'm wrong, is it seems that chiropractor, there's very much two different streams. There's much more the sort of traditional philosophical one, there's much more the more sort of more musculoskeletal,
scientific, research-based, evidence-based practice. My group that I'm now the patron of, it had a few different name changes, but it's now called Chiropractic Australia, and that's the postgraduate educational group. We tend to attract the more evidence-based practitioners to come to our lectures, and I usually lecture at every major conference on something to do with surgery or whatever, but we often bring in rheumatologists and other medical specialists to give a chunk of some sort of information for them. So we don't get the fire and brimstone chiropractors coming along, and they're still out there, the philosophical people, if you like, who think that they can treat diabetes by manipulating the spine, those sorts of things. These are the guys that give the chiro profession a bad name, and they're the ones that end up in the newspapers. Unfortunately, that's, we can't stop them.
With your unique background and with some of the skills and knowledge you've developed from chiropractic that you apply even now as a surgeon, how a lot of your colleagues within the medical field look at you? Is their eyebrows raised, or are a lot of them quite open and curious to what you do?
Look, when I went back into medicine as a medical student, I was at the Royal Melbourne Hospital, everyone knew who I was.
Right.
They were watching me carefully. I made sure that I got pretty much straight honours in everything that I did. So I won them over, and then I started my junior house training, if you like, the residency, and I got pretty good references everywhere I went there. Then when I tried to get onto the orthopedic training program, that was a different matter, and I was seen with some suspicion, and I can tell you, I can't name him, but I'm not allowed to. But there was one of the senior orthopods that said to the head of the unit, "As long as I'm alive, no chiropractor will ever become an orthopedic surgeon." And this filtered through the other heads of the department, right to the professor of surgery. And when they didn't accept me, I went to see him because he was one of my referees. And he said, I'm the director of training in Victoria. I can overturn any decision that's been made, but I'm not going to use this power. I'm going to make them all feel very uncomfortable. And you're going to come and do a year of clinical research with me, a master's in surgery, which I did. And I did that. And the next year, they didn't even ask me a question. They said, "You're on."
So you basically had to prove yourself a little bit more than
a little bit more, yeah. I mean, that was only a few of the orthopods that were suspicious, and those guys ended up coming to me as patients.
Yeah.
Yeah, for their back problems.
Yeah.
You know, so there's been quite a turnaround.
Yeah, I think it's one of the issues that can often stifle innovation is this unwillingness to be open to outside information. I know that's something for me I've noticed where, like going back to talking about particular training I've done with like fascial manipulation, which doesn't seem, it's not a big thing in Australia at all. No. But I mean, for me, there's actually really good science behind what they do, but more importantly, clinically, it's so valuable. But I don't know if that's an issue we have particularly in Australia, or if it's just related to people wanting to protect their profession individually. But it's, I think there's a good opportunity to learn a lot more if we open up talking to people from different approaches.
Yeah, go ahead, Dave.
It's a bit like racial prejudice, you know. You don't understand what's going on in somebody else's domain, so you fear it, or you don't want to know about it, or it's the same thing. It's not, unfortunately, the cooperation, it's coming slowly, but it's not as fast as I would have hoped, or I thought by now, we would have chiros in public hospitals. I'm just about to start an approach to Epworth Hospital, because some of the chiros are getting more into rehabilitation, and they've put forward a proposal to come into private hospitals to work with the physios with rehabilitation. And that seems to be a big thing, and this week I'm going to be talking to the rehab people at Epworth about this proposal that's come from WA, from the University of WA, from the chiros there. Yeah.
Very interesting. It's going back a little bit, but do you feel like the manual therapy training was useful in your picking up on some of the surgical skills with your hands?
I don't think so, because the manual therapy is all sort of from outside, and it's all, sort of long lever techniques and short lever techniques, on the vertebra and that sort of stuff. So I don't think that that's necessarily helped my surgical.
Do you think there's a way of thinking though about picking up the skills with your hands? It's something that, like, we've spoken with a number of the surgeons that have come in, how surgery in itself and the skills of surgery are different to other areas of medicine. It's not just about understanding, say, what's going on. You actually need to develop the soft skills of being able to feel things.
Yes, is the answer. You have to. It's a totally different skill set, I think, to anything else that you get taught, and I think it's quite different to manual therapy as well. As Jack knows, you've been to watch me operate. I rely very heavily on the operating microscope in spine surgery, because that just gives you a whole new dimension of seeing things and being a lot more accurate. Often you've got just a millimetre of room to play with before damaging a nerve or something like that, or getting a dural tear. And I think the microscope has been a crucial skill that I learnt in England and brought back to Australia, that a lot of people weren't using. Now it was always very commonplace for the neurosurgeons to use the microscope, because that's part of their intracranial training, but not so much the orthopods. You don't see too many orthopods using an operating microscope.
And is that still the case?
Yes.
Why is that? They just don't know how to use it?
It's not part of the training. I just, fortunately, I was in the operating room at Nottingham, England, and we had a fellow who was visiting from Austria, and he said, "Look at that." I said, "What?" He said, "Under that sheet over there is a microscope." And I said, "Well, what's that?" And he said, "Look, I'll teach you how to use it." He said, "You'll love it." So we dragged it out. No one was using it. And so we pulled it out and we did a few operations with it, and I thought, geez, this is fantastic. This is much better than wearing magnifying loupes or whatever. And so I became, as you know, I pretty much use it every operation I do.
Yeah, but hasn't that had quite significant effects too on... Well, I remember actually Nolan telling me about this, about you really changing some of the surgical times for some of the common surgeries that you do, in terms of being able to reduce it.
I think being able to see better with the scope and developing the hand skills and having a great assistant like Tim, as you've met, our surgical times are pretty quick compared to everybody else. That's good for the patient.
Yeah.
It means the wound is not open as long and less prone to infection, and I've got probably one of the lowest infection rates, certainly at the Epworth, I was told. And it means less anaesthetic time, so the patients recover faster. it's better for everyone.
Are they teaching people that now as you're going forward to use those things, or is
No.
it not? Why would that be the case if you're finding that actually from a success rate in terms of some of the key measures like infection?
I don't know is the answer. I don't
Are
know.
you involved in any of the surgical training at the moment?
I was, but again, when I was in the public system, and I did that for a long time at the Austin and the Royal Melbourne and a bit at Monash, I was running around Melbourne 7 days a week, and then I was training the registrars, but at that time most of the registrars were interested in doing hips and knees, rather than spines. So, and sporting injuries, those sorts of things.
Yeah, that didn't change. I know you mentioned that before we started, but because I remember you, once upon a time you saying that a lot of people want to do spinal. They weren't interested in doing the spinal surgery specialisation. They were much more interested in going to lower limb or upper limb.
Yeah, it's still not a very popular subspecialty. Most of the trainees would still go for non-spinal orthopedics.
The most of the population group you work with are more general population as opposed to non-athlete population. Is that correct, or do you get a mix?
I get quite a mixture.
Okay.
So.
Well, that'd be interesting because I know one of the things I was interested to talk to you about was thinking about, particularly in more the general population, understanding how comorbidities are a factor associated with the overall state of the musculoskeletal system, but also related to the severity of pain or causing pain conditions. So have you developed a particular framework that you use clinically when you're dealing with, say, more general populations with a lot of comorbidities to determine the success of surgery, or whether you think conservative management is more appropriate?
I think each patient or each case has to be assessed on its merits, and you've got to. It's a balance between the fitness of the patient and their comorbidities and the risk of the surgery and the potential outcome. So the patient's selection for the operation is always based on a multifactorial decision-making basis.
Have you seen any particular, from your clinical experience, observed certain types of comorbidities associated with the more likelihood of getting surgery? Like, for instance, if someone does have more clear indications of, say, spinal nerve root compression that's causing lower limb radicular pain or radiculopathy, the likelihood of then that being resolved conservatively as opposed to not, based on lifestyle factors?
Yeah, I mean, if you take, let's just boil it down to the most simple area of a lumbar disc prolapse, and people say to me, how old are people with lumbar disc prolapse? Well, the youngest I've operated on has been 14, and the oldest I've operated on has been 94.
Yeah.
Wow. Okay.
So
There's a range.
Yeah, there's quite a range. 80% of lumbar disc prolapses, as you know, will settle down over 6 to 8 weeks, and the sciatica will resolve with the body's ability, hopefully, to reabsorb the nuclear material that's either bulged out or extruded. And the extrusions, the sequestrations, seem to have a greater propensity for resolving. Because I don't know, I think the white blood cells and the macrophages can get at them easier, I suppose. So, people say to me, and I lecture on this extensively, when do you do a microdiscectomy or discectomy? And it's really a case of, has the patient given it enough time conservatively? Is it getting better day by day? Well, if it's getting better, then you let sleeping dogs lie and keep going. Is it getting worse? Are they developing motor weakness with it? Which is almost a tipping point for me. If you start to get a foot drop or something like that, it's no way to go through life. If you're left with motor weakness, these are the things you've got to consider about maybe operating sooner rather than later. Do you try an epidural injection of steroid? Which can be helpful in the small disc prolapses, but unlikely to help in the larger ones. So every case is a little bit different, and this is the art in deciding, rather than the science, and deciding when to operate or not.
Yeah, look, this question really comes from looking at some of, is it Nicholas
Bogduk?
Yeah, we're looking at the actual mechanical compression of a nerve not being the big driver for, well, from what I understand, at least a big, or the only driver at least, for developing lower limb symptoms or upper limb symptoms, we're talking about the neck, but really more that inflammatory response associated with the compression.
Yeah, it's a little bit of a grey area. It's not so much the compression. It's sort, and I know Nick, and I've had lectured with him, and I've had many arguments with him as well. He has his own theories, and Nick's more a scientist than a clinician, of course.
Yes.
But he's done some fine work over the years. I think it's the common theories at the moment is that the pressure causes venous stasis of the nerve, and so it's almost like an anoxic thing that causes the pain.
Yes.
Yes, some people also feel that there's an inflammatory component. When you operate, sheaths are supposed to look white, and often when we get in there, as you might have seen when you've been with me, Jack, in the theatre, is that there can be a redness around the nerve, and this is sort of in what we call injection or inflammation or engorgement of the small vessels. And it's felt that this is part of the pathophysiology that causes the pain, and it's the anoxia of the actual nervous tissue itself that causes the pain. That's my undertaking of it, of course.
What's your disagreement with Nick? What's his contention and what's yours? Or some of?
I won't go into that.
No, it's probably interesting for people to hear.
Look, he has his theories on how to treat people, and I have my theories on how to treat people. Nick is, I guess he doesn't get the opportunity to see inside an operation, and this is where a lot of physios and chiros and osteos also don't actually see what's going on inside. They can only look at pictures in textbooks, whereas we actually get in there, we can see it and touch it and know what's going on. So I think that gives us a better sort of clinical appreciation of what needs to happen.
Do you think there's any, well, when you think about more clear structural damage within the spine, and again we can think about, say, disc pathology and associated nerve root compression, have you observed with patients that you've sent off for conservative management, or even in your own experience as a chiropractor, particular conservative interventions that can be more useful or are more useful than others?
In the case of prolapse or in the case of degenerative disc disease?
No, probably more prolapse.
Prolapse. Yes. I think it's more a case of time rather than anything else, and whenever I lecture to the physios or the chiros on disc prolapse, I always say, by all means, don't send the patient to me on day one. You do what you can with them and give them some education, and probably don't do any vigorous side-lying adjustments or manipulations, because that, every year I see people who have been manipulated with a disc prolapse and they've turned into a quarter equina compression, and it ends up in court, and I have to write reports, and everyone ends in tears, really. So, but I often say, well, look, you could try a little bit of, do your soft tissue work, do your trigger point therapy to reduce the symptoms, do your dry needling if that's what you want to do a bit of traction, I think that's helpful, and if you want to give them some exercises to do, I normally say they're pretty safe in the swimming pool. And I'm a good believer in hydrotherapy, but try and make the patient take on some responsibility for their own condition and do some things themselves. But it's probably more a time issue for the body to see whether it can resolve the bulge. And I've seen some huge lumbar disc prolapses that you think, my God, the quarter equina's under threat here. And the patients have said, no, I'm not going to have an operation. I see them 12 months later, we re-image them, and it's gone.
Yeah, wow.
So that was one of your questions, I think, that you gave to me about, do you see regeneration or improvement in the disc? Well, it's not so much regeneration like a flat disc becoming big again, but it's more resolution of the actual physical bulge.
It's interesting you say that, because one of the things we even hear often is that people will come back and they say, oh, I have a disc bulge, and you say, okay, well, when was, and they might not be related to this specific injury, you're just asking them about their medical history, and they'll say, oh, 10 years ago. There seems to be this common held idea that they don't, as you said, they don't repair or they don't resolve in some manner, but the evidence would suggest that there is a reasonable chance for that to occur. How do you think we sort of get that message out about, the education side of that? Because there is this idea of, I hurt my back 10 years ago, and so therefore it's a lifelong sentence of back pain, or the pathology will never resolve.
There's probably two parts of that question, the symptoms being either axial back pain or neurological pain, radiating sciatica. So, the axial back pain, I usually say to them, well, really, surgery is not a good thing, for this. You've got to do lifestyle changes, you've got to go see your physio, chiro, osteo, get your core stability exercises under control, accept the fact that you can't dig up the backyard in one go anymore, be sensible with what you've got. Realise that you've got not a normal back, but also patients, they sometimes read the radiology report or the GPs will tell them, this is what you've got, and they freak out.
Yeah.
Oh my God, I've got a disc bulge. Well, I can tell you, if I scan you two guys and myself, you'll probably have them non-symptomatic disc bulges as well. So it can be very dangerous for the patient to read the conclusion of the MRI report. They fixate on whatever the radiologist has said, and the radiologist has got to call it as he calls it. He doesn't see the patient clinically, and he says, oh well, there's a right L5S1 disc prolapse, and they come to me and they say, well, the GP said, I've got to see you about my L5S1 disc prolapse. So have you got any sciatica? No.
Yeah.
Well, what do you want me to do about it then?
Well, I think that the better radiologists do seem to comment, if particularly with spinal, I've noticed, they will comment if matching clinical symptoms may be appropriate for X or Y or Z.
Yes.
As I said, some of them don't comment that, but I always find that super helpful because I think it sends the message, at least to the patient, because in your mind you're thinking the same thing. Are the symptoms I'm seeing consistent with what the imaging says? Because if they're not, maybe you're better, as you said, to let sleeping dogs lie.
No, it's not very common for the radiologist to say that. Sometimes I'll say, if clinically appropriate, send them back to me and I'll do a CT guided injection. I think that's good business practice, but that's got to be really a decision between the clinician, the treating clinician, and the patient. Yeah. So, but it's not common for them to say that. But
one of the things that I wanted to ask you, because it's one of the hardest things I think to deal with, is patients in pain, particularly with the spine. It tends to be not only a very uncomfortable condition, but there seems to be a lot of fear and anxiety around what that means.
There's a lot of negative connotations associated with it.
How do you manage that, obviously with the level of experience you have? Because I'm finding over time, the education that you have to give needs to be able to demonstrate to them that unless they're getting some of those more severe symptoms, as you said, that creates the idea of motor changes or neurological symptoms, that the pain that they have, one, has the opportunity to resolve, but two, they don't need to have necessarily these negative connotations associated with that, in the same way that they wouldn't if they, say, really severely rolled their ankle. They can't really walk, it's really painful, but they don't have these negative ideas in their head that, oh no, I'm stuffed forever here. How do you manage that?
It's very difficult to instill realistic expectations into a patient. And sometimes they get frustrated with me or angry with me because they think, everyone said to me, you're the best, so I'm coming to the best, and now I want you to operate and fix it. And I'm trying to point out to them there is no magic wand for this condition. You have some permanent damage. You're going to have to live with it and modify your lifestyle. You're going to have to get some good advice from your physio, chiro, osteo, whatever, and follow their advice. Don't go to them for 6 weeks and think, I'm fixed now. This is going to be a lifelong thing. Maybe you have to go and visit your conservative practitioner, once every few months, get your exercises reviewed, get some hands-on therapy, that sort of thing, and you manage it. It's not that someone is going to be there to take it away from you. That's not going to happen. And some of them accept that advice and some don't.
Yeah, I just find it always really interesting, the difference between, say peripheral versus, spinal regions, where people just don't seem to deal with the level of pain in the same way. They think of it very differently. Yeah. Even if there isn't, say, as you said, neurological symptoms associated with it, which in our minds, I think clinically we always, at least I do, as soon as you don't have those symptoms, you're thinking, okay, well, this isn't that severe, right? But you don't want to just downplay the level of pain that someone is in, because obviously that experience in itself is not fun.
I guess with spinal pain, in particularly low back pain, it's there sort of with you moving, it's there when you bend, it's there when you lift, it's there when you sit for too long, drive for too long. So it's probably more a functional impact on their life, whereas if you've got a bit of an arthritic knee, well, you can wear a knee brace, you can not put so much weight through it, the pain goes away when you sit down, that sort of stuff, So
alter activities that you do, so you're not applying so much compressive load through it. Now, one of the questions, going back to before, talking about regeneration of the disc, because I know there's some research of looking at how, say, submaximal running can actually improve disc height.
By imbibation of sucking water in, I think is what you said. That's something that I've not seen. I mean, the research, like Nick Bogdak and the researchers, probably better to ask that question of. So I probably can't give you an answer there. The improvements that I see structurally on MRI have been basically resolution of prolapse.
Yeah, so reduction of...
Yeah. So we don't I've not seen, a skinny disc become fat again by doing
whatever
teaser training or Pilates or whatever,
no, look, it's something that I'm interested in. We've talked a little bit about here, because when we think about articular tissue, it's typically seen as non-regenerative.
Yes.
And it's interesting, I know there's a couple of papers, and I think a lot of this is really more based on animal models, but looking at the role of autophagy, which I don't know if you've heard of autophagy, but it's the cellular process that goes on the cleaning up, essentially, this system. But it only occurs in certain circumstances, and it only occurs typically when you upregulate the AMPK cellular pathway. So that's associated with being, like, say, in a fasting state or post, like, endurance activity.
Or low caloric state,
Or low caloric state. And the idea is that because the cells within articular tissue cannot replicate, if you go through the process of autophagy, of breaking down degraded tissue, it provides biomaterials that you can use to then alter the extracellular matrix and actually regenerate it. But then that also is not going to occur for most people in the general population, because they're not in a healthy enough state to actually experience autophagy, because they're either in a hypercaloric state or never in a fasted state, or don't do any physical activity.
I don't know a lot about that, except to say I would pronounce it autophagy. Auto meaning self, and phagy meaning to eat yourself.
Sure.
So I probably don't know too much about that. We were taught a little bit about loading and unloading the disc to increase the H2O compensation, the in self-imbibation, but I'm not sure that that's been proven either. I'd go to Nick Bogdak's research on that, I think, to look at that.
Yeah, well, I mean, it's probably a good example, though, too, of what may sound good in theory may not actually happen in the real world.
Yes, yeah.
Are you seeing much innovation within medicine, of looking at how you can potentially regenerate tissue through new technology or
gene therapies and things like that? Look, I think that's it's being done probably more overseas than here, and I have had patients who have gone and had this treatment in India and China, and they've paid tens of thousands of dollars, and I haven't seen any sort of startling results so far. So I think that's still a way off as far as a therapeutic modality.
Is there anything that, whether it be in the surgical world or not necessarily these sort of gene therapies, that is interesting you, that you feel like, okay, this innovation shows something that you're going to sort of keep tabs on going forward?
Every year there's something new on the market that comes out, and that was one of the questions I think you were going to ask
technology
me.
And things like that.
Technology. A lot of this stuff is market driven, and the companies that make, like the interspinal spacers and X-lifts and things like that, they sort of market this stuff, and it's the sort of more enthusiastic surgeons grasp at it as a new technology, and I usually stand back from it and let's see how things go. And then a lot of these things disappear from the market as they've been proven not to actually do anything, or just increase the risk of the surgery, and not be of any benefit. So there's been heaps of things in my experience in the last 25 years as I've been involved with spine surgery that have come and gone because of that. So I, again, with my conservative approach, I tend to steer clear of things like that until they've been absolutely proven to be of benefit. I mean, I use pedicle screws and cages and those sorts of things, implants from my fusion surgeries, and I can be swayed into a new type of cage with a new coating on it, but it's basically...
It's the same technology.
Yes, it's an orange is an orange, whether it's a navel or a, whatever sort of thing. So, yes, I move with the times when there's been little changes in the surface coatings or whatever, but as far as, major technique changes, I would prefer to wait and see that they're useful.
It's something that we've asked a number of the surgeons, and I'm interested to hear your idea on it because you sound like you've been innovative across your whole career. Surgeons tend to somewhat be more innovative than other areas of medicine. They tend to be willing to explore things, whether it be through their clinical research that they do. They're often involved in studies. Do you think that there's something about particularly surgery itself and who's drawn to surgery that makes them a little bit more adventurous when it comes to innovation?
Well, I guess, innovation or trying new techniques, that comes about because you're not happy with the results you're getting with what you're doing. Look, I see a lot of innovation in the medical fields as well with the physicians as far as drug trials, and they're going on all the time. So I don't see the surgeons being more innovative than the physicians, necessarily so, apart from the fact that drug companies obviously push their products forward, but the implant companies are always looking at trying to get a bigger slice of the market by doing something slightly different to their metalware, or inventing a new device. Those interspinous devices, the things where you stick it between the lumbar spine to prevent movement. Well, that was done in the 1930s and found not to work. And then what happens? 10 years ago, it's reinvented, and people are doing it. And then 5 years later, they figure out, it doesn't work now like it didn't work in the 1930s, and they're scrapped. They're gone from the market now.
Do you think that that's with experience you've learned to sort of stand back and wait? Because I think it's something that's saying, everything that is old is now new again. You see these cycles happen, and I think Jack and I are probably starting to see some of these cycles even in our own career. We've only been out 10, 12 years, but you start to see things, you're like, I remember that, like 10 years ago, and it's come back around again.
And particularly when you talk to some older clinicians as well.
They always talk about this concept that, we saw that 30 years ago or 40 years ago. And for you, as you said, you just mentioned the 1930s proved that probably wasn't a useful technique. Is that something that you think you develop as you get further down the path, that, okay, like I need to be a little bit more cautious with that decision making? I
think I've always been a bit cautious, and I've always been sceptical about new things. So I don't think my scepticism has changed in the last 25, 30 years that I've been involved with surgery. I guess when you're talking about physio techniques, I know when I was a boy, ultrasound was the thing to do, for all sorts of musculoskeletal injuries. And I started saying, the ultrasound waves penetrate a centimetre? How's it getting down to 6 centimetres down to a facet joint, or whatever?
It's very funny you say that. In my second year of physio, I got myself into a lot of trouble asking the same questions. I sort of was walking around saying, well, this is all rubbish. Why are we even learning this stuff anymore? And I ended up nearly getting into quite a bit of trouble, because I was like, I'm not even considering this as being reasonable.
I gave a lecture in Noosa a couple of years ago to a group of physios up there, and I mentioned this very thing, and 3 or 4 of the physios stood up and said, ultrasound's garbage, we don't use that anymore. And then 2 or 3 of the older physios up the back got up, and there was almost a punch-up.
Oh, really?
Yeah, so this is the basis of my treatment. I've been doing ultrasound for 60 years, and and I sort of said, well, there's no scientific evidence that it actually penetrates more than
a centimetre or so.
So what's it doing?
Maybe a good example of, if you have strongly held belief in something, you can really elicit a large placebo effect.
Well, that's true too.
Oh, good. Is there anything else you wanted to talk about, John?
No. Was there anything that you wanted to put forward, David? You happy with the messages you got across? Is there anything else you wanted to discuss?
Oh, look, I think so. I think the basic message is spinal surgery is very good for certain things, and the results can be great, but the spinal surgery for inappropriate conditions can be disastrous. And so the basic thing is, for me, you've got to really select your patient well and do the right operation for the right condition.
Actually, there was a question I wanted to ask. I'm not actually aware of the epidemiological data, but has the prevalence of back pain been getting worse over the last few decades?
I don't think I could answer that.
Yeah,
I don't think I have enough epidemiological evidence for that.
Or even like the amount of serious types of pathology that require surgery, or again, you're not sure?
Not really sure about that. I don't think I...
In your own viewing of it, have you seen the population change, or that is coming to see you, or do you think maybe that's a factor of you being a very experienced surgeon and people referring a specific type of patient to you?
I don't think I've seen a change in 25 years of the population. It's still quite bare, as I said, 14 to 94. Actually, the youngest patient I've ever operated on was 3 months old, and that was for a congenital scoliosis.
Yeah.
I never want to do that again. That was frightening.
Yeah, I can imagine.
Absolutely.
So
how do you actually? Here's a question for you. How do you actually deal with some of those more serious, significant surgical interventions you need to do for the simple reason that this is potentially what is most important for their health, but you as a person, not just as a medical professional, actually has to take on that burden of doing that job? Is that difficult at times?
I think the main thing there is proper informed consent for the patient. I usually say to every patient that I'm going to operate on, I cannot give you a gilt-edge guarantee that you're going to get the result that you want. If it's something simple like a disc prolapse, I can usually say, you've got a very high percentage. But if it's like a fusion for back pain, and I'm very strict on my indications for that, even if they've got a lytic spondylolisthesis or single level really severe degenerative disc, I can say, look, I can do a perfect operation, but I still can't guarantee that you're going to be perfect and back playing football or anything like that. You've got to accept that, and you've got to accept the possible complications of general anaesthesia, nerve damage, infection, etc. that may come along with that. And that's the way I inform them. And if they've got a cancer or something like that, I'll say, well, we can do what we can, but this is probably not going to be a curative operation, but it may give you a bit more time, and it may prevent cord compression or cord recliner compression or something like that, and improve the quality, but there's only so much I can do.
Okay. David, thank you very much for joining us.
Pleasure.
This episode of Lateral Think is brought to you with the support of Strength by Numbers. Strength by Numbers have created an integrated clinical and sports performance system. The AXIT system uses force plates, dynamometry and strain gauges to objectively measure everything from isolated movements to sports performance tasks. The system has greatly enhanced our clinical practice, decision making and objectivity. We are no longer guessing. The greatest thing is its ease of use both for practitioners and for clients. There are no wires, no fixed setup. It is a fully integrated Bluetooth system. If this sounds like something that would enhance your practice, visit strengthbynumbers.com and tell them that Melbourne Athletic Development sent you.